Good afternoon, and thank you for joining today's webinar. We certainly appreciate you taking time out of a busy holiday season to review this webinar on Health IT 2017 Year in Review and 2018 Blueprint for Success. We'll get started in just a moment. Wait for a few more participants to join. Okay, let's get started. Thanks again for joining. I'll begin by discussing a bit about Galen Healthcare Solutions for those of you who aren't familiar with Galen. We were established in 2005 by three former Allscripts employees. We've worked with over 500 customers during the past 12 or so years. Those ranging from public HIEs, private HIEs, accountable care organizations, small specialty provider groups to large integrated health delivery networks. We have three components to our company. Those include professional services or application expertise, technical services, and our products team, where we offer an archival solution as our flagship product. Our teams have been recognized for best-in-class, #1 rankings in HIT implementation and staffing, and #1 in technical services. And we are very proud of our heritage in that we've been ranked 5 years running now as a best place to work in modern healthcare. We have offices in Boston, Chicago, and Burlington. Our services and solutions, we offer core services around data migration, integration, EMR optimization, operations support, and of course, as I mentioned, clinical archive. So a lot of the engagements we've worked on over the past couple of years have surrounded the notion of data archival, clinical data archival, and clinical data migration. And as such, you can see through the statistics, we've encountered a great number of systems and a great variability in the types of data we've been able to migrate and archive. And that will be a key topic for today. That theme of data migration and archival has been a baseline in healthcare IT for the past few years, as there have been mergers and acquisitions and consolidation in the industry. So our agenda for today, our small team, consisting of myself and another strategist at Galen, we, in attending conferences, in participating in our CHIME interview series where we interview CIOs on various topics, we've distilled what we think are the key themes that we recognized in 2017, and also attempted to put together a practical roadmap or resource for groups to use as they approach 2018. Now, by no means do we think this will be applicable to anyone and everyone, so we tried to cover a broad area of topics while also getting into the specificity of how you can make this actionable to drive results in 2018. So, in 2017, well, what happened? A lot around privacy and security. I think the newsworthy items were weekly on that topic. However, consolidation, mergers and acquisitions, both on the health delivery organization side and the vendor side, dominated. We noted key acquisitions were Allscripts' acquisition of McKesson back during the summer, their health information systems business. And then recently, Optum's acquisition of Advisory Board. And very fresh off the news is the CVS-Aetna merger, and there are a lot of implications to that from a consumer point of view with healthcare information technology. Now, this year was a bit different in years past because I think there's this underlying notion of national health policy uncertainty. So certainly you had folks who were a bit skittish about investing or knowing what areas to focus on. And as such, a great many groups, and in fact HIMSS, they moved the MRAM evaluation to consider more of hardening security and privacy. There still is this move from fee-for-service to value-based care, and obviously a lot of initiatives around that. But to no one's surprise, Epic and Cerner continue to dominate both the inpatient and outpatient EMR market, and that's because of integrated solutions between different care settings. So let's start first with the topic of data migration and archival. And for those who might be having trouble with audio, you should call into the webinar. I will make a note in the chat window. Replacement drivers, a lot of the consolidation in any market you see, there's a rationalization that happens. A market starts out as fragmented and you are able to achieve economies of scale as the market consolidates. And some statistics back this, namely that 50% of all healthcare organizations will be on their second EMR by 2020. What drives this? Well, a Black Book report revealed that a lot of clinicians aren't having a good experience with these EMRs, and certainly a lot of groups describe the EMR, EHR as clunky, and they cite those deficiencies in usability and also interoperability as drivers for replacement. So a single database integrated system is obviously a lot more desirable as we see this consolidation happening in the provider space. EMR and EHR replacement drivers, we touched on these a bit. The main reasons to replace, aside from an integrated solution, is standardization of the system. This is a topic we'll delve into a little bit more when we touch on master data management and data governance. But for those clinicians, those folks in health IT on the webinar today, you can appreciate the different dictionaries in play. And there's a litany of standards out there, and some that are proprietary, right? So I think of all the dictionaries that have to be maintained for labs, right, who don't go off of a global standard. Another topic is the voice of the client reaching product development. As vendors have themselves merged or acquired, there's some rationalization they have to do that may impact, the level of service they're providing to their clients. So the top features of replacement, aside from the obvious notions of the EMR's use, is customizable templates, certainly patient tracking. You're seeing a move, obviously, to patient engagement and building in tools so that the initial intake can be automated. And another topic we'll touch on is virtual visits. We're seeing those start to take off as well. So one of the core items, I guess, to EMR replacement or EHR replacement is clinical data migration. And not a lot of people appreciate the the big forklift that it takes in moving clinical data from one system to another. because not only do you have to consider the data itself, you also have to consider the metadata. For instance, if a provider made a clinical decision on 12/22/2014, the chart may have changed since then drastically, and as such, if there is an audit that takes place, what clinical information was presented to the provider at that point in time, it's going to be different than the current date and time. That's just one example. Another is, as groups are acquired, you may acquire a small specialty practice as part of the larger health system, and you wish to bring them over to the Epic EMR, the Cerner EMR from whatever legacy EMR they came from. Certainly there's a lot of harmonization, rationalization, and reconciliation, more importantly, that has to occur when you're bringing in their clinical data, especially as you consider they have their own dictionaries that they maintain across this time. So there's a lot that goes into this. It's anywhere from 3-month to 6-month to year-long project, depending on the scope. And certainly if the data cannot be migrated and the legacy EMR turned off, there is an approach to sunset the legacy system by archiving. So clinical data archival, it's really caught on the past several years as healthcare executives have had these cat and dog systems that they've maintained with large swaths of data. And, you know, perhaps migrating data is not feasible, and you need to maintain those systems from a compliance perspective, but also from a clinical continuity perspective. So the key points to note about clinical data archival is that migrating data to a new EMR is not an archival strategy. A lot of times what will happen is you'll only migrate a subset of data that's applicable, and then you'll need to archive the rest. The ability to offer robust legal and clinical archives can be greatly affected by approaches to extraction, transformation, and loading and storage of the data. And a lot of the archival solutions in the market today make trade-offs, sacrificing end-user accessibility for implementation speed and cost, or vice versa. These legacy systems they accumulate technical debt over time. Obviously, there's licensing costs to them. There's inherent risk if the product is unsupported or you don't move to the latest version of the product. There's also expertise that you need to maintain from the team's perspective to continue to support that. And the risk increases over time, obviously. The longer a legacy system must be maintained, the greater the risk involved. Knowledge atrophies, as do platforms. And as such, last year, or early last year, rather this year, I'm thinking 2018 already, early in 2017, our Vice President of Product Development put together a white paper that articulated how to evaluate different archival solutions, the trade-offs that exist between extraction and load implementations, data visualization, data fidelity, and accessibility, both from a clinical and compliance perspective. What's important to note here is that whenever you move data from one system to another, you inherently could change the shape of that data. And I mentioned the metadata being so important, both from a client compliance and clinical perspective. As notes evolve over time, you must maintain those different versions of the notes, for instance. So for those groups, it's more than likely you're going to encounter M&A and some sort of consolidation or some sort of system you need to sunset. So this will be an area of focus for you in 2018, regardless of what type of organization you belong to. Our next topic is patient engagement. Excuse me. So telehealth has really taken on in that it can now be reimbursed. Most plans, public and private, will reimburse for telehealth. However, we haven't witnessed as much adoption. So this is an area of opportunity for a lot of healthcare delivery organizations in 2018. there are a lot of benefits to telehealth, and as you start competing with CVS's and the Aetnas of the world now, and they're really optimizing that consumer experience, it's important to offer different visit types. Organizations that have adopted telemedicine services reported more than the majority reported more than 20% savings, and that's not insignificant. But more than the savings, you're offering the patient a better experience, not necessarily through the first visit. You probably want that first visit to be in person, but certainly for subsequent visits and subsequent scenarios, given what you're seeing that particular provider for, it may make sense to have a remote visit. And so the obvious benefits of telehealth are patient share capture, revenue gain from new visit types, new patients who you might not have seen in a normal visit type, revenue loss from patients leaving the healthcare delivery organization to one that offers e-visits, and then expanded capacity. This is a big one. By shifting those visits to e-visits, perhaps you don't see as many cancellations, and you're able to open up your schedule a little bit more. And then the key point that we touched on, the avoided costs, lower acute care costs for payers through increased lower acuity access. Taking advantage of telehealth with Epic, in this scenario, we examine the adoption of telehealth specific to Epic. The keys to success for this particular case study is that you want to target a specific patient population. So, for instance, as I mentioned, 70% of new patients choose to have their first appointment in person. In addition, you may have folks who are disabled or who would need some help getting to the office. They make a heck of a lot of sense to have a remote visit with if you're just checking up on their range of motion and you can validate things visually rather than needing them to be physically present. In addition, you can integrate the virtual service as a tool within the primary care clinic, prioritizing that seamless user experience and building virtual visits into the existing primary care relationships rather than positioning it as a substitute. This is important. It's not meant to replace the normal visit type. It's meant to simply supplement it and offer some more flexibility to that. And as we move from fee-for-service, obviously, to value-based care, you want to defer the acute visits, and this offers a way to do that through seeing the patient through another modality. And I mentioned we examined this with Epic, knowing that a lot of users out there, Epic has quite a bit of market share. What we witnessed in our research was that it wasn't as adopted as we thought. So we think there's a great opportunity in 2018 for those users of Epic to really examine whether they're taking advantage of this, because it would be a small step function to enter into telehealth. Moving on to clinical decision support, what was staggering to us in reviewing the Class 2017 Sepsis Detection and Prevention Report was, to us, this should be ubiquitous in adoption. Every group should adopt this capability, given that if the functionality exists, it should seem like a no-brainer, given just the amount of patients it affects each year. About 250,000 patients, costing more than $20 billion annually. And the detection is fairly straightforward, right? There's no there's no variability to this detection. There's a tried and true formula to it that can be realized through rules that throw alerts in the clinical system. That said, as part of that report that was published by Class, as you see, 41% of folks who use Epic mention difficulty in adopting that sepsis solution. And in fact, I was just talking with the CMIO at Rush Health, and he was mentioning that they actually went to an external solution from Wolters Kluwer. And the reason they went to that external solution is due to the sensitivity and sensitivity and the specificity of the solution that was inherent to Epic. Namely, when we talk about sepsis, the sensitivity is the ability of a test to recognize true positives, while the specificity measures number of true negatives correctly identified. In a screening test for a potentially life-threatening disease, such as severe sepsis, high sensitivity would be valued over high specificity so that cases are not missed. There are hundreds of rules built into these platforms to account for possible comorbidities and medication abnormalities and trigger alerts. What's important to note, though, is the level of sensitivity and specificity. The last thing you want to do is cry wolf and inundate your providers with false positives. The gentleman I had spoke to at Rush, he had mentioned Wolters Kluwer had seen great unprecedented levels of sensitivity and specificity in the area of 90% as published in a study. However, again, in 2018, for those groups who haven't adopted this yet, who may feel like it's a significant step function to adopt within Epic, you may seek external solutions. And in fact, at Rush, they integrated NLP with sepsis detection so that they were able to harvest some information out of the note as well and combine that, coalesce that with the discrete data. And probably the meatiest of the topics we'll talk about today is data-driven clinical optimization. Not just clinical optimization, but data-driven. And this was an important point that was uttered over and over again at the CHIME Fall Forum Conference, namely harvesting data, operational data out of the system to transform the user experience, the usability, and efficiency of the EMR. I think a lot of people take the approach of, well, you know, I just need to adjust a workflow and reduce the clicks. It's not necessarily about reducing the clicks. It could be a training issue. It could be, you know, the provider's not doing their job. They're doing a job that could be done further downstream in terms of documentation. And the only way to identify that is by examining the data. Being a self-identified data geek, it's important to take that operational data and use it to transform maybe how clinicians are interacting with the EMR. And important to that is that it's top of mind for healthcare organizations. So 38% of those who were surveyed, they thought their capital investment priorities over the next 3 years would be heavily in EMR system optimization. So it's really taken on some energy. There's a lot of energy behind it. As we saw in CHIME, they introduced a new clinical informatics track as part of the CHIME Fall Forum this year. And as groups start to try and rationalize that EMR investment, they need to recognize better performance out of it. If they made this big investment in an EMR and they're not getting that ROI on it, obviously an organization can go further into debt. And the key here is not seeing the EMR as the center of the universe, or it's an end-all be-all, but rather strategic objectives are the center of the universe, and an EMR supplements that. In fact, we published a clinical optimization white paper along with Sue Shade and Jim Boyle over the summer, and we solicited their feedback on the important notions. And it was Sue who said, once the go live is complete and you've stabilized, you start looking at the growing optimization list. She noted that it's important that you have clear governance and have a partnership with your clinicians in IT so that clinicians with the support from leadership are driving the high priority changes that are needed in the optimization effort. Jim echoed that sentiment, and actually at St. Joe's, they form a dyad relationship with administrators and clinicians, and it was a point that was uttered or echoed by Dr. Tom Silva and Brian Blavin of Missouri Health as they presented on optimization at Chime, to the point where IT needs to work hand in hand with clinicians and not sort of not one group drive the initiative over the other, not necessarily IT driving it, not necessarily the clinical side driving it, but working jointly. And that's achieved through a governance process where you form those relationships between IT and the clinician. In terms of areas that you can focus on, obviously, in care coordination, there's a lot around reducing the average length of stay, reducing duplicate lab testing, but also improving that physician user experience. And it's staggering, if you improve their experience, those cost savings are reported as a side effect almost of that. As articulated in an op-ed authored by Drs. John Levinson, Bruce Price, and Vikas Sani, they mentioned how really it's staggering that the provider is losing more and more face time as they feel like they're shackled to the EMR to fulfill documentation requirements. I included a graphic here, that data visualization that was produced by Arcadia Health, and what they did was tracked the life of a provider, the life and the day of the provider. And this is the data-driven piece I was alluding to. So you can see how a provider's day may be extended because of unexpected events, and perhaps they're spending too much time in a particular encounter, a particular visit, and as a result of that, they're working into the night. So there's a lot of initiatives around the topic of clinical cycle management. And what I mean by that is it's akin to revenue cycle management. A lot of folks will be shifting their focus from revenue cycle management to clinical cycle management. Where are providers spending their time within the system? Are those activities that other lower credentialed providers could be doing downstream, and that allows more face time with the patient? How do they perform against their peers? And this proof of concept we developed around clinical cycle management shows the potential to automate some of the workflow by giving the clinician the chance to design that. So within this flow designer concept that we put together, if there's an activity that the provider is repeatedly engaging in, is there the opportunity to automate that for them to so that they can allow more face time with the patient? And so, again, as we talk about, well, what can I do in 2018 in this realm? Well, if you're an Epic or Cerner user, you should take advantage of the inherent capabilities that they offer. Namely, with Epic, that is the provider efficiency profiles. It takes data about users' interactions with Epic and creates a picture about how providers are using the system in order to identify efficiency and training opportunities. Similarly, Cerner, with its Lights On network, allows for you to get information about the provider experience and promote best practices, identify areas for retraining and monitoring performance of key clinical activities. A point that was noted by Dr. Tom Silva while we were at Chime, and he presented on the topic of physician engagement, they actually positioned across from the clinician break room, a retraining area. So they had someone from IT who was on staff who sat there, and as they went on break, they could stop in and have a short 10 to 15-minute retrain opportunity. So you're meeting the clinicians where they are and making it convenient for them. And these simple concepts are so important as you aim to identify and prevent burnout, quite frankly. Which providers are showing as outliers versus their peers, and why? The answer is in the data. It's using the tools to harvest that and making the appropriate adjustments to workflow. And so the only way you're going to impact that behavior is by measuring efficiency and performance. So actually, Dr. Tom Silva presented the graphic to the right. He showed how their dynamic documentation that they implemented, it saved providers from spending time outside of their normal business hours on documentation. And as I mentioned, some of that consists of automation, some of that consists of moving the documentation upstream and away from the provider acutely. And in addition, on the left-hand side here, you get, if you were to measure provider performance, you can see some of the areas around clinical efficiency, clinical quality. These two really go hand in hand. So a potential motivation for providers to comply is maybe you bonus them based upon how they're using the system. And benchmarking, this is so critical, and class has done some great stuff with the Arch Collaborative, where they're allowing organizations to find out how well they're doing in deploying an EMR. Similar to MRAM offers some guidelines, the MRAM adoption score offers some guidelines, but the class piece examines survey data, and that's an important point. If you're not doing surveys today, you've got to do surveys to your end users at least twice a year. Again, combining that with the operational data, you're able to get a clear picture of end user sentiment, but also end user behavior, and reconcile those two so you can become more efficient and productive. Through the Arch Collaborative, you're able to see clinician satisfaction for your organization, how you compare to other organizations. Are you improving? What areas, what specialties need addressing? Is our EMR governance model working? Is our training effective, or is our organization wasting money? And what is the connection between physician burnout and our EMR? So all of this data, and it's a very comprehensive survey, I encourage you to take a look at it if you haven't already, is available, and you can really hone in and target those areas to improve the experience with the EMR. Moving on to clinical documentation improvement. A little bit of background on hierarchical condition categories. That was a risk adjustment model implemented by CMS in the beginning of 2004. What it does is it allocates appropriate reimbursement for patient complexity by condition category, or HCC. Only direct patient care activities related to HCC-related diagnosis in a particular time frame are used to adjust the following year's payment per patient. So as the graph to the left shows, there's ever-rising enrollment in Medicare Advantage, an increasing share of the Medicare population, and it's the fastest growing or faster growing payments versus other plans. So for those groups where this makes sense based upon the type of patient population that you're serving, it's important to know, to appreciate the challenges with regard to managing HCCs, namely undetected year-to-year care gaps that lead to omissions, lack of electronic medical record interoperability that prevents information sharing, lack of provider education about documentation coding specificity. Some providers think that, or I guess in certain scenarios, you may have to document something every year rather than just once. And then the absence of professional coders to help providers maintain compliance. So for those unfamiliar with HCC, there's a base demographic risk score that's based on hard-coded numbers, including age, residence, and Medicaid disability interaction. And then, of course, the disease risk score, so the comorbidities. The risk factor is determined from those disease risk scores, and the only way you're going to maximize, obviously, your payment is if you're accurate in those disease risk scores. However, there's a counter to that. If you embellish and you come under audit, there are certainly some penalties that can be levied as well. So it's important to engage providers in HCC capture if that's something that's meaningful, if there is a big Medicare Advantage population. We note, though, that more private insurers are moving to this. And a solution to this is a joint educational, technological, and reporting solution. You really need to put reporting in place to identify gaps in the documentation. And counterclaims are essential under value-based reimbursement because with the correct HCCs, your patients are appropriately risk-adjusted to meet most VBR program requirements. There are 3 common reasons why HCC diagnosis can go missing on encounter claims, namely the clinical providers do not document the HCC-linked diagnoses for their patients. Clinicians document a patient's relevant conditions but do not code for the conditions, and the patients in an attributed population for a health system do not come in for a visit during the required time period, so there's no opportunity to capture that relevant diagnosis for these patients. Again, it starts with capturing the data and then measuring, identifying those gaps, retraining with the provider to help them understand where the documentation should be captured. So for some groups, this will represent a big area of focus in 2018. Interoperability, the elephant in the room. I think everyone appreciates and loves FHIR and SMART, but don't know where to get started. And Showmark Research did a tremendous job covering this domain and published what is now a publicly available white paper on the topic of how healthcare organizations can get started with APIs. I think there's the example that's often used or cited is at Boston Children's with the SMART growth charts that they enabled through SMART on FHIR. But if you're not ready to jump into app development, an easy way to get started is to start an API program by simply extracting data. Can you use a REST API, make a call to that REST API to extract data and harvest that data for whatever use it may be from a reporting perspective. You want to press the EMR and EHR vendors to continue to evolve their capabilities. In fact, we attended the Meditech Physician and CIO Forum, Fall Forum in Foxborough in the fall, and it was refreshing to see that they were really focused on enriching their APIs, and they had some pilots occurring with some of their Meditech clients. Begin API governance discussions. Of course, who has access to the data? Should they have access to the data? Privacy and security concerns, those need to take place as well. And really concentrate on EHR user experience issues before functional enhancements. So is there an alert you can pop up, perhaps using SMART on FHIR to show that this patient fits a certain category and to flag the provider? There's really small entry points to demonstrate it, and that way, it's just like anything. If you start practicing your use of that, you'll develop the internal expertise and be in a good position when these standards really start to proliferate. Of course, for those organizations who do not have an EMPI in place today, it's a must. There's no question about it. We don't see us going to a national patient identifier anytime soon, and this is a very costly domain. Namely, according to an ONC report, each case of misidentification at the Mayo Clinic costs at least $1,200. Intermountain Healthcare spends between $4 million and $5 million a year on technologies and processes intended to ensure correct patient identification. Not only is there a monetary aspect to it, it's a safety issue, quite frankly. 8 to 12% of hospitals' medical records are duplicates, and on average, 64 to 96,000 medical records refer to a patient with another existing medical record. And, you know, the list of statistics goes on and on. So if you have not done so already, alleviate yourself those manual patient matches and put together an RFI or an RFP for a enterprise master patient index solution. And if you have it in place, evaluate it. Is it working to your liking? We interviewed Todd Rogow with HealthX in New York, and they had a nice whiz-bang patient identification solution that worked off of a different type of algorithm that allowed them to really get at the outliers that they were seeing in patient identification. And I'll include that as a follow-up when we publish the slides. I'll identify that solution that Todd was using. So we've talked about patient identification. Let's move to data governance, and we also talked about interoperability in that regard. What's been an initiative or a project that's been in place for quite some time now is the Yosemite project, and what that project is geared towards is articulating a technical roadmap with two major themes: standardize the standards and crowdsource translations. You remember I talked about dictionaries and how many dictionaries need to be maintained from a healthcare perspective? Well, the Yosemite project, what they identified is it's crazy. Why is everyone maintaining all these different standardizations? Why isn't there a master library? And so what their roadmap is based on is the use of the resource description framework as a universal information representation. They envision a web-based repository that allows translation roles, aka translators or mapping roles, to be shared and reused. Well, what does this mean for a healthcare organization? If you are on the path of data governance, or you are maybe have an area to improve data governance, I would inquire to the Yosemite project, because they have a plethora of resources that can be used for best practices as you launch a data governance program. Now, from a data governance perspective, the other topic that we must discuss is master data management. Master data is critical business data shared amongst multiple systems. In healthcare, we divide master data into two types: identity data, such as patient and provider, and location identifiers, and then reference data, which includes common linkable vocabulary like ICD, DRG, SNOMED, LOINC, RxNorm, etc. Three main drivers are making master data management more important than ever in healthcare, namely the mergers and acquisitions that we talked about, because data configuration of multiple providers are usually so different, MDM is needed to merge the data. Health information exchanges to successfully exchange information across locations and organizations. HIEs have to be able to reconcile that master data. And then accountable care organizations to understand and manage their patient populations. ACOs bring together health systems data and payer data. This process demands solid master data management. And for those where there are not a standard, I touched on labs being one where Quest has their own lab code, LabCorp has their own lab code. Allergies is another where it is user-defined, and as such, I'd mentioned in the previous slide, the Yosemite Project's initiative to standardize those standards, you need to establish translations. If you're maintaining those different systems in the enterprise, it's important to have a library of translations and or simply standardize on one. And that's where a master data management solution can come into play and be quite beneficial. Moving on to the topic of data stewardship, the first component of the slide title here. The triple aim of data governance is ensuring data quality, building data literacy, and also maximizing data exploitation for the organization's benefit. As such, the data steward's an emerging and very important role in healthcare. Those data steward candidates are employees who are at the front lines of data collection in the organization and understand how that data is collected within the system and how to get at that data, and how the information systems that support those areas collect the data and report on it. And so your data stewards are the equivalents of subject area experts in library, for instance. Health data stewards can include nurses, physicians, registration clerks, registry managers, billing and coding staff, cost accounting staff, and researchers. Health Catalyst has a great amount of material on data stewards, but it's an important role where you want to make sure in your healthcare organization you have you have talent and you have expertise in that arena. And if you're an analyst or in an analyst role today, it may be an area where you look to gain some competency to grow within your own organization, understanding that topic and learning more about it. So, in summary, what are our New Year's resolutions? Mine's to lose some weight, I think, with everyone, exercise more, right? But in all seriousness, from a healthcare IT perspective, what we wanted to do was outline areas where you can move the needle, where you can devote energy to. So number one, rationalizing your portfolio by retiring legacy applications and archiving. Number two, start an API pilot project focused on data extraction or device integration. Number three, adopt Sepsis surveillance dashboard or just an existing solution to optimize alerting if providers aren't really seeing any benefit out of it because it's flying too many false positives. Target specific patient populations to introduce e-visits and configure the EMR accordingly to do so. Measure physician satisfaction with surveys. Those can be external or internal, but at least should be done twice a year. And optimize through rounding, retraining, and automation. So what you want to do after you measure through the survey, you want to report on that and identify gaps and areas of opportunity. Improve clinical documentation efficiency and accuracy through adoption of smart form or equivalent and gap identification reporting so that you're able to optimize payments in those risk share models. And lastly, identify organizational data stewards and govern through master data management. As the deluge of data continues, you want someone who can navigate that data and be that domain expertise that you can, that domain expert that you can go to in order to harvest data, but also provide the right access to the right people. In summary, I encourage you to visit our Knowledge Center. As I had mentioned, in order to put this webinar together, we conduct interviews with CIOs as part of the Chime series. We attend events. Not only do we put webinars on, but we try to articulate some of our findings or communicate some of our findings through blogs, through our monthly newsletters that we launched. And an area that we're really focused on is the high-end thought leadership around white papers, playbooks, and infographics so that we can distill original thought and more so act as a resource to healthcare organizations as they navigate uncertainty in the political landscape. There's certainly areas where you can move the needle for your healthcare organization and position yourself for success. And as always, we encourage folks to take a look if there's an area of research that you're interested in. Please don't hesitate to reach out to us. We'd love to work with you. And any questions at all, I would ask that you submit those to the chat window. We will certainly be providing today's deck. The webinar is recorded, so we'll share that on our YouTube channel, and I'll follow up with a link to that at the conclusion of the webinar. So it doesn't look like there are any questions. Everyone's ready to get into holiday mode, getting ready for their holiday parties. I hope that everyone has a very safe and very enjoyable holiday. Lastly, as a last pitch for Galen, I'll mention that our team, we have a lot of pride in our heritage. As I mentioned, we have multiple platform expertise. We have a core Epic team of employees, and our team, the differentiation is really around our collaborative nature. We're nimble, personable, and ego-free. We always like the client to take all the credit. So with that said, as I mentioned, I hope you have an enjoyable holiday, and we'll see you at the next Galen Healthcare Solutions webinar.